Welcome everyone. I'm continuing where Dr. Bomarty left off. He discussed renal blood flow in glomerular filtration. I'm going to be talking about tubular reabsorption, tubular secretion, and how to assess renal function. Okay, so markers of renal function. I just want to kind of reiterate that what can happen in the kidney when blood flows through it. There are several things that can happen, and so Dr. Bomarty already talked about one of the most important functions of the kidney, and that is filtration. That happens at each glomerulus, and there's about a million nephrons, and therefore a million glomeruli in each kidney. Every one of those glomeruli would be filtering blood, and by filtering, just to reiterate, that means the blood cells are not going through, right? That should not happen, but the fluid is going through, and along with the fluid would be small molecules. Anything smaller than about 65,000 grams per mole, or anything really smaller than albumin should be filtered. Okay, so what if something does get filtered? Does that mean that it's always going to end up in the urine? Believe it or not, the answer is no. So just because something got filtered, that doesn't mean it's destined to enter the final urine. Okay, so that's just the very beginning. That's the very beginning of the tubule, and that's called ultrafiltration. Again, that's just the very start of it. Okay, and that's what we're going to be talking. We're going to be talking about what happens. So what happens after either the substance gets filtered, or if it never got filtered, and that's going to be secretion that we'll talk about later. But if something never got filtered and it just continued in the arterioles, so went to the efferent arteriole and bypassed the glomerulus. Does that mean it's destined to never enter the urine? Actually, the answer to that is no as well. That means it still has a chance of getting into the urine, and that would be secretion. So we're going to first start on reabsorption, right, and then we'll get into the secretion. So reabsorption returns most of the filtered water and solutes to the blood through that process. So that means, basically you're filtering about 20% of all the blood that goes through the kidney. About 20% of that fluid gets into the tubules, but most of that is reabsorbed. Otherwise, you'd have to urinate all the time. Your bladder would be full all the time. So you're actually reabsorbing most water. And actually, in states of dehydration, you would reabsorb even more water to try to prevent any further dehydration. So along with the water, major solutes are reabsorbed. That would be glucose, amino acids, urea, and a lot of electrolytes. If you constantly urinated all your electrolytes that were filtered, you would be deficient, right? You'd have basically electrolyte abnormalities, and you'd basically be deficient. So the kidney is critical with maintaining electrolyte status. So if you have impaired reabsorption, like I said, you lose electrolytes. On the other hand, if you had impaired filtration, which Dr. Bomarty talked about, right? So if you had impaired filtration, you would accumulate too many electrolytes. So you have to have a perfect balance. You have to have filtration, you have to have reabsorption, and you also have to have secretion happening at a productive rate. So something actually being reabsorbed can take at least two different routes, really two main routes. So this on the left here would be the urine that is forming. It's just the very beginning. And I'm actually, in most cases, when I'm talking about reabsorption and secretion, I'm referring in many cases to the proximal tubule, which is the beginning, right after the glomerulus, and that's because most of the work is done there. So what could happen is, for example, sodium might be able to go between cells. That would be paracellular. Sodium can also be transported across the apical membrane and then separately across the basolateral membrane. So these two membranes have very different transporters in many cases for each ion or any substance that's being transported. And then that will go into the interstitial fluid, diffuse into the peritubular capillary. This is also called the vasa recta, which is the entire capillary system that is parallel with your tubular cells. Is called the vasa recta. Again, it's a peritubular capillary, and things are diffusing into that. And once they reach the capillary, they can go back to the venules, back to the rest of the body to be redistributed throughout the body. So again, paracellular and transcellular reabsorption can be passive, which would be more the case for smaller things and maybe some nonpolar things, or active, which would require transporters, right? Could be primary or secondary or even tertiary active transport, depending. Um, some people define and actually characterize a tertiary, a third type of active transport. I'm not sure if you've learned about that, but it's okay either way. Um, so just a good example here would be glucose. Glucose is so important, so I'm going to focus on that for this example. Um, I don't know if you're aware of this, but if someone, if you measure glucose in someone's urine, if someone does not have diabetes, they should have basically zero glucose in their urine. And the question I would ask is, does that mean that glucose never gets filtered to the glomerulus? And the answer should always be based on your knowledge of the size. So if you know glucose is smaller than albumin, which is, I don't know, it's probably hundreds of times or thousands maybe of times smaller than albumin. So it's a very, obviously a tiny molecule. So glucose, because of its size, that you should automatically conclude it's probably filtered, right? Because it is not stuck on albumin, it's not stuck on other plasma proteins, and if you know it's freely available, and that means it will be filtered. So glucose is filtered. So how come it's not in the urine? And that's simply because it's reabsorbed. So imagine up here the glomerulus is filtering a lot of glucose, right? It's bulk flow. So 20% of fluid is going through, 20% of glucose is going through. So they go together. It's just a very very non-selective. It's like a sieve or a colander that you would use for pasta, right? So it's just filtering a lot of stuff that's small will go right through. Okay, that's small enough, and that will travel down. Okay, but at some point, usually in the proximal tubule, things are reabsorbed, and glucose is reabsorbed in the proximal tubule. There's actually very similar to the gastrointestinal system. There is a sodium glucose cotransporter. That one of them that's really well known now, because there are several drugs that inhibit that, is SGLT2. So the SGLT2 inhibitors are Flozin types of drugs, would block a sodium glucose transporter, and that's it's used for to get glucose out of the body, so to keep it into the urine there, keep it in the urine. But normally what happens is that sodium gradient is required to drive glucose in, right? And that all starts off with energy in the form of ATP that's driving the sodium potassium ATPase pump, which would be here. So that gradient is formed, and that actually results in a deficiency or a lack of sodium within the cell, and that drives the sodium in. Right, that'll drive it in, and that'll pull glucose in, and then we have other transporters on the basolateral side to allow it to go through that side, and then the interstitium, and then diffuse into the capillary. So that's just one example, but that same thing happens with medications. It happens with electrolytes. So glucose is a really good example. So if this gets saturated, imagine. So this is not a passive, not really a passive process. And this is a mediated process, and by mediated I mean that it requires a transporter or carrier. So if this carrier, if it could only carry so much glucose at a time, and that is true, right? It'll grab a molecule, bring it in, grab a molecule, bring it in. That means it can be saturated. That means it can be overloaded. So if that gets overloaded, you overload reabsorption, and then you have more glucose going down, and then it ends up going eventually into the bladder, and then you're urinating glucose. So that'd be the example. If you have too much glucose in the urine, you saturate transport. Okay, so that is what you see basically in diabetes. And that's right here. To make it more clear, I have it all on this diagram. So let's start on the bottom here. And first of all, and I'm sorry that's for some reason that's a little cut off on the slideshow on Panopto, so I apologize, but I'll just tell you the units is milligrams per deciliter or milligrams per 100 milliliters. So plasma glucose is here. So this is how much is in your blood or your plasma, the concentration of glucose. On the y-axis, we have how much glucose is filtered. glucose filtered load, reabsorption. I'm sorry, it's actually all three of them: glucose filtered load, reabsorption, or excretion. So it depends on the color. So each one has a different is basically meaning a different thing. So essentially, if we're looking at normal. I don't know if you're aware of this, but normal glucose is usually like between 70 and 100 or 70 to 110. So if we were at a normal glucose level in our blood, so go up and see the reabsorption is blue. Reabsorption is identical to filtration here. Do you see this? So the orange is filtration, the blue is reabsorption. Those are on top of each other. That means 100% of what is filtered is reabsorbed. That means 0% should show up in the urine because all of it is kind of recuperated or reabsorbed before it courses through the whole tubule. It's taken back into the blood. That's why we have the green here being at 0, right? You don't even see the green line here because we have 0 excretion. So what'll happen is if you go too high, if your blood glucose gets high, and then all of a sudden, you, again, 200 milligrams per deciliter is pretty high. It's basically abnormally high glucose. What'll happen is you will start to see it, the green line here, you start to see it showing up in the urine, and that's called excretion, right? Just to remind you, excretion means something is leaving the body, whereas secretion means something is moving from one compartment to another compartment. So excretion means, the glucose is leaving through the urine. So we should not see it being excreted there, but it is. And that should match up top here. We should see a diversion of filtration and reabsorption. So filtration is exceeding or higher than reabsorption. That means we've actually filtered too much because there's too much in the blood, and our reabsorptive transporters are saturated, right? So that sodium glucose transporter is saturated, and it's overwhelmed. So some of the glucose will go right past it and go into the urine, right? So that's why reabsorption is important, because normally it would pull all of it back in, but it is sensitive in the sense that it can be easily saturated, unfortunately. Another one is sodium that I wanted to mention. Sodium is actually the most abundant cation in the ultrafiltrate, coming through the glomerulus. It's almost always through active transport, and actually the entire, and I already alluded to this, but the entire driving force for sodium to move is starting off with a sodium-potassium ATPase pump, and that's coupled to ATP. So that pump is forcing sodium actually against its concentration gradient, forcing it out of the cells. It's producing a driving force to pull sodium into the cell from the other side, okay, through the apical side. We already kind of talked about that. This slide is just showing you that our the balance of water and sodium, but this one is particularly water. The balance should be, it should be 0, right? So that, what I mean by that is the amount of fluid that we take in should be equal to the amount of fluid that we put out. Otherwise, you'll constantly be being swollen, bigger and bigger, like I think it was Violet from Charlie in the Chocolate Factory, or Willy Wonka in the Chocolate Factory. You'll keep getting bigger and bigger and bigger, or smaller and smaller and smaller, until you're desiccated to nothing, like a raisin. So you have to have a perfect balance. And some of that intake is in liquids, some of it is in a lot of, the foods are, of course, they're not 100% desiccated, where they would just be powder. So bread and things, it's going to have moisture in it. And then we produce water through a lot of metabolic processes have water as a byproduct, right? Through enzyme cleavage will result in excess water. So this is about the total, about almost 3 liters. And we're losing our water, believe it or not. Look at this. So 900 milliliters through something that's insensible. That means you don't really feel it. So your skin, and I don't mean sweat, because that comes next, but I mean your skin is constantly evaporating moisture that you don't feel, and that is a large amount of moisture. And when you exhale, you're having humidity, right, in your exhalation, and that adds up to quite a bit of water. There's a little bit in sweat, and of course this could vary. Some people, when they exercise, will sweat like 5 times more than somebody else, for instance. So depends on the person. And feces, a small amount. And then urine is about double the insensible loss. So obviously a significant amount there. So we already talked a little bit about how sodium gets reabsorbed. This slide is just kind of meant to show you how sodium and water really have to go, they don't have to go together, but sodium generally would start that driving force. Not in every case, but sodium being the driving force, meaning that when sodium goes in and gets reabsorbed, then water will follow that. Now, I just want to clarify that in some cases, in one of the most important things I'm going to talk about is aquaporins, and those are actually water channels that take water only and not sodium. But regardless of that, the water is going to follow where the osmolarity is higher. So that is a lot of that is generated by sodium anyway. So I just wanted to kind of piece that together on this slide to show you that they're connected. And it's pretty, I think, pretty obvious. We've all learned a little bit about osmosis at some point. But sodium is reabsorbed. It's part passive, part active, but it really, in the end, it's really tied to ATP. So either directly or indirectly, we need energy consumption. It's in most tubular segments, just not the descending limb of the loop of Henle, where you have sodium reabsorption. Water reabsorption occurs mainly by diffusion, but there are specific water channels that are really important. In the proximal tubule, there are always expressed, which are called aquaporins, and also aquaporins in the collecting tubule. And then there are some other just areas throughout the kidney where there's going to be diffusion of water. And the aquaporins were discovered. I think it was well over 10 years ago, but there was a Nobel Prize. Someone won the Nobel Prize for that. I think it was multiple scientists, but really exciting that they actually found that water has specifically engineered channels just to carry that, which is kind of cool, and it's simple and elegant in a sense. Aquaporins are highly expressed, like I said, in the proximal tubule and the collecting duct, so I mentioned that. This is really a key point here. The aquaporins are based on antidiuretic hormone activity. So what this says here is aquaporins are always in the proximal tubule, but in the collecting ducts or collecting tubules, which are right next to each other, right? The ducts and the tubules. The duct would be where all the tubules come together. The collecting tubule will be just the end of each nephron, and then after that we'd have the ducts. But it doesn't matter. For our purposes, we can use either one when we're discussing this. But essentially, antidiuretic hormone is necessary, and that's coming from the pituitary gland. That is necessary to trigger insertion of aquaporins into the apical membrane in this collecting duct or collecting tubule, where the urine is going to be. So we are regulating urine or water reabsorption at the end of the tubules, specifically through antidiuretic hormone. And that's why when we talked about that in cardio, that's why I really emphasized antidiuretic hormone and its relationship with angiotensin II, which is a trigger for ADH release. So please understand that vasopressin is the same as antidiuretic hormone. And that's pretty much it for this slide. The next couple slides are just showing you graphically kind of what sodium looks like, sodium reabsorption. First of all, in the proximal tubule. We have a few different ways of getting it in. You don't have to know the specific transporters there, but just please understand, bare minimum, that the basolateral side has a sodium-potassium ATPase pump. I want you to understand that this pump requires the consumption of energy. That's cleavage of ATP. So even though on this side it's not primary active, it is still requiring energy, which is generated on this side. So remember the sodium-potassium ATPase pump. I think you'll learn about all the way back in the first course in biology, Bio 121, or depending on where you're from or what school you went to, might be a different number. But basically, the first biology. And the reason why this works is as sodium is going out this side. This size here is meant to indicate kind of the concentration. So it's a lower concentration inside, a higher concentration outside. In that deficiency, relative deficiency in here is because of this active pumping. So we're pumping it against its gradient. It actually doesn't want to go this way. But this forces a deficiency, and that draws more sodium in from the other side. And that's how we have sodium reabsorption. And that's always happening in the proximal tubule. If we go, this is more sophisticated in the collecting tubule or collecting duct. Sodium reabsorption is primarily dictated by aldosterone. Remember, aldosterone is triggered by angiotensin II, which is triggered by renin release, which is triggered by low blood pressure. It's all connected. That was all in cardio, and I think it's helpful that cardio was before this, so you can make more sense out of this. But aldosterone, when that is elevated, it's going to basically trigger, or you get really any aldosterone in these collecting tubule cells, it's going to, and this is transcriptional, so it's going to actually have a nuclear receptor that we'll talk about, but that is going to activate sodium channels, upregulate sodium channels. So the more aldosterone you have, the more sodium channels in the collecting tubule, the more sodium reabsorption. And you still have water reabsorption in the collecting tubule, so this would help with that too. You get some sodium in, you can also get really the fine tuning at the end of water reabsorption, the very last bit of it. And I believe, so this is where I originally left out those last 3 slides. I accidentally paused the slideshow. So this is where it's going to continue from the original slideshow. So I'm just going to go ahead and stop it here. And then we're going to continue on this slide. So that the vasopressin that's released from the pituitary gland will activate its receptor, and that will upregulate aquaporins, which will, as water is flowing down the lumen, that will cause reabsorption of water here. And then we have actually aquaporins on the basolateral membrane as well. So those are pretty much always there, but the aquaporins on the apical membrane are going to be regulated by vasopressin. So this is why it's critical to understand that the cardiovascular information. So when we talked about, when your angiotensin II is produced, it does a lot of things. And one of the things it does is it binds to receptors, basically in the central nervous system. It'll be binding to receptors, actually in the pituitary gland, releasing antidiuretic hormone. So angiotensin II triggers antidiuretic hormone release. Remember, what caused all that to begin with was low blood pressure. So you have to always be thinking, is the body doing the right thing then to counteract that? And it should be, right? So it should be counteracting the low blood pressure. So how does it do that? Well, would it make more sense to reabsorb more water into the blood or get more water into the urine? And of course, if your blood pressure is too low, you want to get more fluid back into the blood, right, to raise the blood pressure. So you want to upregulate aquaporins through vasopressin, right, and right here. So the more water channels or aquaporins, the more water goes in, the less water will be urinated. So again, more ADH, that means more antidiuresis, means less urination, and this is the mechanism. So this is pretty simple. I didn't want to spend a lot of time on this, but this is just showing you how sodium and water are kind of tied together. As sodium goes in, that creates hyperosmolarity, right? Increase in osmolarity in the interstitial fluid. Okay, this is the urine. This is the urine side. On the right side is the interstitial fluid in the blood. So what'll happen is, anywhere in the tubule where sodium goes in, that'll create a driving force for water to follow. And generally, this is osmosis here, but this is not going to be as prominent as the effect of the aquaporins. Okay, so it doesn't mean, so I wasn't saying, or I didn't want to imply that no water can come through osmosis, but a lot of it will come through and be finely regulated actually by the aquaporins. Okay, as we get to the second half of the proximal convoluted tubule, that doesn't mean the second half of the nephron, but the second half of that first segment, which is the proximal tubule. We do have electrochemical gradients that promote some ions to be diffusing just passively. So a lot of these electrolytes here will just passively diffuse based on their concentration gradients. And they're small enough that they don't all need specific channels or transporters. to get back in to the blood. So that actually wraps up reabsorption. Okay, so the next topic is going to be secretion, which is just the opposite. So again, sometimes students, I know they struggle with differentiating between filtration, reabsorption, secretion, and excretion. And those are all very different and all very important to understand. So I'll just reiterate that filtration is the only one, filtration, compared to reabsorption and secretion, filtration is just very passive. So if the fluid is there and there's a pressure, right, through the hydrostatic pressure in the glomerulus, the fluid will be filtered along with the solutes. However, reabsorption, again, reabsorption is going to depend on transporters. In some cases, there's some diffusion. Secretion is also going to depend on transporters. So if remember, if something doesn't get filtered at the glomerulus, right? So if something goes past the glomerulus and it goes into the efferent arteriole, that's still going to be next to the nephron. It's the efferent arteriole travels down to the vasa recta or peritubular capillaries, and it's named that way. The peritubular capillaries are named that way because they're next to or peri to the tubules. So they go in parallel with the tubules. So that means if something didn't get filtered, it still has a chance to leak out of a capillary there next to the nephron and then get transported into the urine or the lumen through secretion. So there's still an opportunity to get rid of a drug. So certain drugs, drug or a substance that's already in the body, certain medications actually require that for optimal activity, like furosemide or Lasix, as that's a diuretic to remove water. That is not very well filtered because it's bound to plasma proteins. A lot of furosemide has to be secreted, and then its actual target is later on in the nephron. Its pharmacological target is later in the nephron. So secretion is really important. It also is one of the main reasons why a lot of toxins are specifically toxic to the kidney, because they go halfway through. That means they get into the cells, but then they can't get out of the tubular cells, and that's like half of secretion. So the total secretion, that means not just part of it, but for a substance really to be legitimately secreted, it has to go all the way from the blood into the urine, right? So that is the movement of substances from the peritubular capillaries across the renal epithelial cells, that's both membranes, apical and basolateral, and then into the lumen. Okay. Secretion can be considered a backup route of entry of substances. Like I said, if they don't get filtered, they might be secreted. Some drugs are secreted more than they're filtered. Like I said, furosemide is one good example. And filtration and secretion are really not similar. The only commonality is that both of them are placing substances into the urine, whereas reabsorption is the opposite. Otherwise, they're very different. Filtration is more passive. Secretion is more active. Secretion can overcome, if a drug is bound or substance is bound to albumin, it doesn't get filtered, but it can still be secreted in many cases. Okay. Like I said, so secretion can be saturated, whereas filtration is very rarely saturated. It's really not saturable for any kind of practical or typical amount of something. Even if you have an abundance of something in the blood, it doesn't generally saturate. Saturating the glomerulus would mean blocking its pores, it happens, but it's not common. Okay, so that saturation of secretion occurs by increasing the concentration of the transporter substrate. So remember I said you could saturate reabsorption if you have excess glucose. You could also saturate secretion. Anything that's too abundant can potentially overwhelm those transporters. Filtration does not remove anything that is bound to albumin, like I said. So let's break this down. So if 80% of a compound is bound to albumin and 20% of the compound is not bound, or it's freely floating in the plasma, only 20% of it is available for filtration. Now remember though, only 20% of your fluid is filtered. So if 20% of fluid is filtered and only 20% of that has free, well, whatever it is, the compound bound to albumin, it could be a free drug. If only 20% of that is free, then it ends up being a very, very small percent. So 20% of 20, what is that? That's 4% of something can actually be filtered if it's bound to albumin, and again, and you have normal glomerular filtration. So it breaks it down, and you actually have a lot less filtered than you might expect. Secretion can overcome that. Secretion later on in the tubule, after the glomerulus, you can actually overcome plasma protein binding through secretory transporters that have a higher affinity for the substance that is being secreted, a higher affinity for that than the albumin or the plasma protein would have for that substance. So again, what is secretion? So I have a little diagram that I made in animation. So secretion is actually the opposite of this. So remember, reabsorption goes this way, secretion goes this way from the blood into the urine. So how might that happen? Well, none of this stuff is very linear. So most of it's transporter based. So if something gets transported by one of these, and I'm going to mention the oats because that's what I studied in graduate school, and a little bit at Wilkes University. I've been studying organic anion transporters, and what happens is, and particularly drugs use the oats, but some other things do as well. Metabolites and things will go in on an organic anion transporter, and then it'll have to find another way to get out on the other side, and it might be through. I'm just showing PGP here because it's a common drug transporter, but PGP actually doesn't handle anions very much. So I'm just putting in kind of like XYZ, could be any transporter, essentially has to do the other one. So the main point here is that both membranes have transporters. So each side has a transporter or several transporters, and each side is really important for this. So to be really secreted all the way, you have to go from here all the way to the urine, and that's actually secretion. If you only go halfway, that's not really secretion. But that is important because that's how some toxins will get stuck. They get stuck in there, like mercury, for example. So a little animation. So here comes the drug molecule or other substance going on an oat, going out on PGP. Again, like I said, that's usually not the PGP usually doesn't work on anions, but just to illustrate the point. Okay, that's how things will get secreted, and that means if it's already here in the blood here, that means it already did not get filtered. It already bypassed the glomerulus. So this is a second opportunity to get into the urine, whereas the glomerulus would have been up here somewhere. Okay, and there's another one I forgot about. Another. Whoop. I think there was another animation. Let's see. No, I guess that was it. So, other than drugs, secreted substances include protons, right? That's critical for basically regulating the pH of the blood. The kidney is a major role in regulating blood pH through reabsorption or secretion of protons. Potassium, ammonia, creatinine. Remember, we haven't really talked too much about this yet, but we will in a little bit. But creatinine is one way we measure. We look at that in the blood or serum creatinine to give us an idea of someone's kidney function. But the reality is, creatinine, it's a little more complicated than that because about 90% of it is filtered, about 10% of it is secreted. So you can actually have an increase in serum creatinine just by blocking its secretion, which may not, in many cases, doesn't necessarily reflect kidney damage. So it's not the best marker, but it is a marker that they use for measuring renal function. So it's supposed to be filtered and secreted. So if that gets escalated or elevates, that could be an indication of something wrong. Tubular secretion is important because it eliminates undesired substances or end products that have reabsorbed by passive processes such as urea and uric acid. Essentially, one of the main purposes of secretion is to get things that do not belong in the blood at the concentration that they're at, if it's too high or they don't belong there, to get them out of the blood. So that would be believe it or not, like neurotransmitter metabolites. It would be metabolic byproducts like maybe lactic acid or something like that. Now, some of that gets filtered, but some of these other things are also secreted like uric acid. And so these have to be removed from the body. So the tubule is very critical for that. It's not just a tube, but just a conduit. It's actively doing things throughout the very beginning and to the end of the tubule. It's transporting things, removing extra potassium, and then, like I said, controlling blood pH. This is a little bit excessive, I think, but I just wanted to illustrate this point or emphasize that the proximal tubule can concentrate things. And what I mean specifically by that is that if you measure the concentration of something in the plasma, and then measure it if you were able to, which is challenging, right? But if you're able to measure the concentration of something inside the renal epithelial cells, and I'll go back and show what it means. In here, if you could measure something in here, in some cases, that is much more concentrated than it is in the blood. And that happens with some toxins like methylmercury and even some drug toxins. Just a few beta-lactams that do that. Some antibiotics, beta-lactam antibiotics that do that. They get concentrated in here so that something that's not toxic to the rest of the body will be toxic in some cases to these tubular cells because it is forced in on one of these transporters. Okay, so that's really all that is saying in this entire slide. Okay, something that might not be well known is that the tubules can metabolize. So most of us probably think, and again, it's really early in the curriculum, so you may not have heard too much about this, but I think most people think metabolism occurs primarily in the liver, and it does, but metabolism can occur in a lot of other organs, the GI tract, the lungs, and another one is the kidney. So renal tubular cells can actually make glucose, and that's more, that's not really metabolism as much as anabolism, but basically the idea is that there's some drug metabolism there. There's some, for example, glucose synthesis. That means if you were if you were on a ketogenic diet or you were depriving yourself of sugars, your kidney can actually produce some of its own glucose to help for energy, especially, like I said, during fasting. It can add it to the blood or it can use it on its own for its own energy. Okay. So next, I want to talk about regulation of the membrane channels and transporters that I talked about. So if all those channels and transporters that I talked about, if they just were there constantly, the same concentration, the same activity level all the time, the kidney would not really be able to adapt to certain situations. Right? In some cases, we need more transporter, and in some cases, we need less transporter or channel. And the example that I already gave was if you're dehydrated, you need to reabsorb more water from the kidney. If you're overhydrated, you need to reabsorb less water from the kidney. So I want to talk about some of those regulatory factors that control secretion and reabsorption. Not really filtration, but again, particularly secretion and reabsorption. Hormones can affect the amount of sodium, chloride, calcium, and water reabsorption, and potassium secretion. Some of those that are important would be the RAS system, antidiuretic hormone, atrial natriuretic peptide. I think Dr. Bomarty talked about that, but I also talked about that in the cardiovascular section, where atrial natriuretic peptide is released when the atria are stretched, when there's too much preload, and again, it all makes sense from a logical perspective. That if there's too much preload, too much stress and pressure in the heart, you would want to reduce blood volume, and we do that through natriuresis or pushing sodium out through the urine. And then parathyroid hormone with respect to calcium homeostasis, and I'm not going to spend a lot of time on PTH because I know Dr. Bomarty already talked about that. Again, we already talked a lot about the RAS system in cardio, so won't spend a lot of time on it. So I want to focus on 4 main ways that angiotensin II affects renal physiology. Rather than talking about the entire body, again, we're focused on the kidney here. First of all, it constricts the efferent arteriole, That's the arteriole that happens after the glomerulus. That it's just like any system that if you restrict the outflow, you're going to raise the pressure inside the system. In this case, you raise the glomerular pressure, and that'll allow it to actually filter adequately. If that is excessive, though, excessive constriction, that could be bad, right? You can have too much glomerular pressure and damage. Angiotensin II directly enhances the reabsorption of sodium and chloride in the proximal convoluted tubule. That means it has we actually have receptors for angiotensin right in the proximal tubule that upregulate sodium and chloride transporters. It triggers the release of ADH from the pituitary gland. We talked about that. That causes water reabsorption in the collecting duct through aquaporins. It stimulates the adrenal cortex to release aldosterone, which also stimulates sodium and water reabsorption. So just a brief review of that. The liver makes angiotensinogen. The kidney makes renin, secretes it. That converts angiotensinogen to angiotensin 1. Angiotensin 1 gets converted to angiotensin 2, actually on the surface of blood vessels through angiotensin converting enzyme, primarily in the lungs and in the kidney blood vessels. Angiotensin 2 will travel to the cardiovascular system, do a lot of things, and also, so the heart and blood vessels, but then also the kidney to basically trigger aldosterone. Aldosterone effects in the kidney, which is coming from the adrenal gland, right? Aldosterone is actually coming from the adrenal cortex. That'll trigger the kidney to reabsorb sodium and water. Angiotensin 2 directly triggers sodium, so that sodium and water reabsorption. So I want you to understand the difference there, or the fact that those both occur. Aldosterone causes sodium and water reabsorption, but then angiotensin 2 does on its own, separately from aldosterone. So there's that extra effect there. So what would happen in the case of low blood pressure or low blood volume? I'm not going to read through everything because we did this in cardio, but talking about the renal baroreceptors and the macula densa, basically everything that's telling the kidney, well, if there's low sodium or low blood volume, we must increase renin to increase angiotensin 2, aldosterone, and then sodium and water excretion would be decreased, right? So if you have low blood volume, that means you need to increase it. So to increase blood volume, you would stop removing sodium and water. You would decrease their excretion. And so I expect you to understand this pathway, but again, we covered most of it, if not all of it, in the cardiovascular section. Next is, so what does aldosterone do in the collecting duct? So actually, I already had a slide a few minutes back. I had a slide on aldosterone in the collecting duct. This is just a little bit more information about how it works. Aldosterone, remember, coming from the adrenal gland, adrenal cortex, aldosterone has receptors, just like any steroid hormone. It has receptors that work on the transcriptional level, so it actually upregulates messenger RNA for sodium channels. So then you get more translation of sodium channels, and you get an influx or an upregulation of them on the apical membrane. I believe that's animated. I'll probably have to remove that drumming effect because it's not very soothing, I suppose, that sound. So I apologize about that. But you're upregulating sodium channels through aldosterone. So this is exactly why aldosterone causes sodium retention and fluid retention. And sometimes that's necessary, again, for hypovolemia, hypovolemic shock. If you have dehydration, you want to increase, basically it's low blood pressure, you want to increase sodium reabsorption by putting more of these channels in. More sodium will come in that case. But again, just one reminder that sodium would not want to come in unless it had a good concentration gradient from inward to outward, or inward to outward. So we need to form that concentration gradient by first making sure the inside of the cell is low in sodium. And that's what this does. The sodium potassium ATPase pumps sodium out, brings potassium in, but as that sodium goes out, it creates a deficiency here, and that drives more sodium to come in. So that's why the whole system works. It's all coupled to this, and eventually or ultimately it's all coupled to energy or ATP hydrolysis. Antidiuretic hormone in water regulation, I wanted to talk about again. The release of antidiuretic hormone is actually caused or triggered by the osmotic pressure of the blood. Actually, if your blood were hyperosmotic or hypertonic, that would make it too many solutes or too little water, right? So you're basically having a salty plasma, right? Very, very loaded with solutes. That means you want to put more just plain water in there, right? So when you're thirsty, you don't drink, well, you might drink salt water, but generally you want plain water, right? So when the body is thirsty, it has a lot of salt and solutes, but it's thirsty for water, it's going to reabsorb water directly rather than reabsorbing sodium first. It can also, again, it can also just reabsorb this plain water, and it does that through antidiuretic hormone, and that's through the aquaporins. So one example is if blood volume is reduced because of decreased fluid intake or injury, the body can become dehydrated. The salts concentrate, raising osmotic pressure. Osmotic pressure activates release, elevated osmosis, or I should say elevated tonicity, right? Hyperosmosis would cause release of antidiuretic hormone. Okay, that basically means that if you are dehydrated, you can have as little as 500 milliliters per day of urine being produced of the original 180 liters that's filtered. So that means you might filter 180 liters of urine through the glomerulus, but only 0.5 liters actually shows up in the urine, and that would happen if you're dehydrated. The good thing is your body will regulate this. So if you're dehydrated, your body will stop urinating, not completely, but it'll reduce the urine production. The problem is you always have to have some urine. You'll never completely stop urine production. So eventually, and we all know this, that maybe it might be like 7 days where you can survive, they say, without water, and that's because you will eventually lose it through evaporation from the skin, and you will still produce urine. Even at, it'll be at a low level, but you'll still produce it. The point is that you can still you can regulate it to produce less or more based on antidiuretic hormone. So plasma volume goes down, circulatory pressure, the blood pressure goes down. That triggers the posterior pituitary to increase vasopressin release. That vasopressin puts aquaporins in the collecting tubules to increase permeability to water, and then you have more water reabsorption. That means less water excretion. This is just showing the opposite, and I won't go through the whole thing. If you, for some reason, you had too much water, and I know for the past few years there have been competitions, some challenges, I should say, online, where people are drinking as much water as they can. People have, believe it or not, they've died from that. People have died from excess water consumption. It's not easy to do in theory, but I guess people have done it. And I was doing some reading on that, and it doesn't take much more than a gallon, not much more than a gallon of water if you consume it immediately. Like as fast as possible. It might be 1.5 to 2 gallons. That could actually cause lethality. But if your body doesn't have enough time to get rid of it. So it's not easy to do, but people have done it. So just give a scenario: if someone is drinking a lot of fluid unnecessarily, or they have hypervolemia in the body. Anyway, the exact opposite would occur, and you'd have a reduction in antidiuretic hormone. So that means less antidiuresis. That means more diuresis, more urination, and that relieves that fluid burden. I don't really like to ask a lot of questions on the test about this because it's not. It is a drug target to some extent, but not very. There's only a few drugs that are even related to this in cardiovascular medicine. I just want you to understand that atrial natriuretic peptide is another way of getting rid of sodium, and then the water will osmotically follow the sodium, and that's through stretching of the atria Why would your atria be stretched? And that's simply because there's either too much preload from venous return or really just too much blood volume. If your atria are stretched, you have extra atrial natriuretic peptide. And all that does is actually increases, first of all, it decreases plasma aldosterone, but it also increases excretion of sodium through blocking reabsorption and blocking GFR, or I'm sorry, increasing GFR, I should say. But I don't really want you to memorize this. I want you to just understand that, at least from this slide, that atrial natriuretic peptide promotes natriuresis. That's what I want you to know. And natriuresis is urination of sodium, because remember, natrium actually is sodium in the periodic table. So it all makes sense. It all comes together. Parathyroid hormone, I don't plan on asking questions about this because it is really, I think it's thoroughly covered in endocrine, but parathyroid hormone would be regulating calcium. So lower than normal calcium stimulates parathyroid hormone to release, the parathyroid glands to release PTH. PTH stimulates cells in the distal convoluted tubes to reabsorb more calcium. Parathyroid hormone also inhibits phosphate reabsorption. Okay, so again, I don't have a lot on that. I do have a slide on the renal regulation of potassium, though. And the reason why I wanted to bring this up is because in the cardiovascular module in pharmacotherapy, there are so many drugs that affect this that you need to understand it. All the drugs that are in the RAS inhibitor class, so that we renin inhibitors like aldosterone or Tecturna, all the ACE inhibitors like enalapril, fosinapril, lisinopril, and all the other ones that I might have forgotten. So ACE inhibitors, like I said, angiotensin receptor blockers, like the sartans, losartan, telmisartan, irbesartan, all those drugs are in the RAS inhibiting system. All those somehow affect this. Okay, I'll just kind of alleviate any kind of stress, or not stress, but suspension. I'll break the suspension I should say the suspense. Sorry, I will break the suspense and tell you that all those drugs that block the RAS system block aldosterone somehow. Either directly or indirectly, they affect aldosterone and they decrease its activity. Okay, so they do the opposite. So they do the opposite of this, but I'll just leave it at that. But I want you to understand in the physiology of it, what does aldosterone do, though? And I already talked about its effects on sodium channels, and this is the exact same location. This is the ductal collecting tubules, which are right next to each other. Aldosterone transcriptionally upregulates sodium channels, but every sodium that comes in creates a driving force to push potassium out. As potassium goes out, it gets excreted from the body. So the whole point there is that more aldosterone activity means more sodium reabsorption, means more potassium excretion. So that's one way of regulating potassium. Okay, again, this whole thing can be modified by drugs that either block aldosterone directly or block the release of aldosterone through inhibiting some other component of the RAS system. Okay, so what I want you to understand basically from this is that at least understand what aldosterone does to potassium levels in the blood, and that though basically it opposes sodium. So more aldosterone means more sodium in the blood being reabsorbed from the kidney. More aldosterone though means less potassium. So sodium and potassium are going to go in the opposite directions. So aldosterone goes up, sodium goes up, potassium goes down. I want you to understand though that does happen in the collecting tubule. It's specifically related to the upregulation of sodium channels through aldosterone activity. Okay, and finally, I have a good number of slides again on aquaporins, and not only aquaporins, but what creates the driving force for water to move. I mentioned just a little bit about that, but I'll just remind you, it's actually simple, and we'll kind of we could make it as simple or as complex as we want, but all it really is that water will follow wherever the solutes go, right? So if there's a hypertonic area, water will go to that area. So that's just simple osmosis. So the one thing that's critical first is the water doesn't really move very well until we have aquaporins or water channels in the collecting tubule. That's first of all. Okay, so we need the channels, and I call those like the toll booths, right? But we also need the traffic. What I mean is, we need an incentive for traffic. So I might regret using this later, but the analogy, since Disney World just closed, you use that analogy that, or really anything that's really got a large kind of a large attraction, right? A lot of people want to go there. That would be the driving force, right? The toll booth would be like the aquaporin going on the highway, right? So you're going to have, essentially we need the toll booth. Actually, we don't, but the toll booth is used to regulate and allow the traffic to flow. Okay, so the more toll booths, the more traffic can get through more efficiently. So if you have one toll booth and a large crowd, a large amount of travelers, it'll take a very long time to get through. The more toll booths, the quicker the traffic will flow. And the traffic in this case is going to be the water flowing. But that's only part of the story, is my point there. So you need the toll booths, which are the aquaporins, but you also need something giving incentive, some driving force that tells the people, well, you should come here. And that would be Disney World, right? Or something else that you actually might enjoy going to. It might not be Disney World. It might be, Monster Truck Rally. Who knows? But going there, what in the kidney is the driving force, right? That would be a hypertonic condition, and this is the interstitium here on the right side. We need that interstitium to be hypertonic, and that will drive the water through. That will give it the driving force. So the two things we need are the aquaporins and the driving force, right? That's the only reason why we get that. We actually get water moving in that direction. So why would a person benefit from having the ability to regulate water reabsorption in the collecting tubule? Obviously, if they're dehydrated, to survive, to prevent urination or reduce it. Water overload, again, the opposite. To get rid of water as soon as possible, we would downregulate aquaporins. So vasopressin or antidiuretic hormone, which is the same thing, through aquaporins, if that can control fluid reabsorption, what questions remain? Okay, the question really is, what is the driving force? And I just mentioned that. So the way I look at it, or a phrase that I use, is an aquaporin without medullary hypertonicity is like a toll booth for a closed highway, right? The booths don't matter when there's no traffic, right? So aquaporins are great only if there's a driving force for water to go through them, right? So we need, I'll just get to the kind of the upshot of that, or the ultimate point here is that the medullary region, which is the inside of the kidney, right, the medulla, that needs to be hypertonic to drive water flow. Okay, so what does that look like? First of all, the renal medulla is loaded with loops of Henle, okay, and collecting ducts. Actually, the proximal tubules are mostly in the cortex, which is on the outside, but the loop of Henle would be more, I would say, definitely deeper in the medulla. That actually creates the hypertonicity. The loop of Henle creates the hypertonicity through transport of sodium and chloride. And we'll talk about that in a little bit in more detail. Also, at the very end of it, urea, the very end of the tubule near the collecting duct, urea is also transported out to raise medullary tonicity. So believe it or not, the medullary interstitium here, which is not in the blood and not in the tubule, but it's outside, the medullary interstitium can reach 1,400 milliosmoles per liter. Okay, so that is more than 4 times the osmolarity of the plasma. And that's in a normal physiological situation. So that's also why there's a high risk of kidney stones and other just different types of kidney stones forming, because very very high osmolarity there, but that also is necessary to drive water reabsorption. So I have a simple one, and then I think and then I have an animation coming right after that. So basically, what happens is at the beginning of the the beginning of the collecting duct being so I'm sorry. The beginning of the collecting duct is about inside this in the tubule is about osmolarity of 300. As you go down, because that's pretty low, and the medulla has a higher osmolarity, that's going to drive the water out of the tubule and into the interstitium. What I don't have on this slide is the capillaries, which will pull the water away back to the rest of the body, which is not here. But these aquaporins are critical for allowing the water to flow out, and again, it's going to go down where it's where there's a higher osmolarity, it'll go out. Okay, but what happens? Let's start from the beginning though. As some water comes down through, and sodium and chloride are going down, down, down. We'll skip this for a second. We'll go here first. When we get to this ascending limb, this is going up, or the ascending limb of the loop of Henle, sodium and chloride are actively transported out against their concentration gradient. So that generates a very high osmolarity down on the bottom. Okay, and when that happens, that will, even though that's later on, this is a constantly repeating cycle. So what will happen is that is happening. That'll draw water out, right, and that'll make this tubular fluid more concentrated. But then as it's traveling, right, more sodium and chloride comes out, and then by the time you reach the distal tubule, the osmolarity there is much lower. Okay, so it's this kind of back and forth from medium osmolarity to high osmolarity to low osmolarity. That's inside the tubule. Okay, but outside the tubule, we have this gradient from top to bottom. As you go deeper and deeper and deeper, it gets to be hyperosmolar. So I think this is a little complicated, so I'll show you the animation. So why don't we first talk about, okay, so, and again, it's not really happening at different times. Everything's happening simultaneously, but to make sense out of it, we'll talk about it this way. So this is your key up the top right, and what is happening is, first of all, sodium and chloride gets filtered at the glomerulus, and that's supposed to represent like salt crystals, even though it's dissolved ions. I'm going to go back a step and show you what happened. The sodium and chloride is more available at the beginning here as we're going. There's a bunch of sodium and chloride available in the tubule, and that gets transported out into the interstitium. But if we go higher and higher and higher, because we've already removed some sodium and chloride, we're losing it. As we go up higher and higher, we're losing the sodium and chloride, so there's less available up the top. So at the very beginning, we're transporting basically more. And that would be down here. So we have a higher amount on bottom and less up top because as we went up and up further, we lost more from the tubule. So that sodium and chloride somewhat would contribute to this high osmolarity down bottom. Okay. Now what I'm showing you here is that some of it's going to go into the vasa recta or peritubular capillaries, and this has an opposite direction to it, opposite flow. And this is called the renal countercurrent multiplier system. As the sodium and chloride gets pulled, some of it gets pulled away. As the solutes reach this area, which is the descending, this over here is the descending limb of the loop of Henle. As this capillary solute reaches that region, it's going to draw water out, okay, because just simple osmosis. The water droplets are coming, they're drawn into the, actually they're drawn in to the interstitium, and then that will go into the capillaries, okay. As that happens, as that water gets removed, the osmolarity inside the tubule is rising, right? Water's getting removed, osmolarity here is going up. That gives us a higher concentration of solutes, and that's sodium and chloride. And now when we get to here again, we have a lot of sodium and chloride available. The transporter will pump it out. Okay, actually it'll be various transporters, but we'll just focus on, just imagine it's a single one for now, just to illustrate the point. Sodium and chloride comes out. The same thing happens. It goes into here. That draws more water. The water gets removed. Okay, more hypertonicity. So over and over and over again. So as the water is removed from here, the sodium and the chloride becomes concentrated. That travels. The same thing repeats. And this eventually reaches an equilibrium. Our medullary tonicity doesn't go up forever, right? It's going to be balanced around 1400. At the very top of the medulla, it's going to be closer to plasma, right, which is close to 300 milliosmoles per kilogram. And again, the bottom is super concentrated. This process will repeat and repeat until it reaches that equilibrium. And the equilibrium allows the deep medulla to be very concentrated. So why does any of that matter? Because this whole medulla is equilibrated. The whole medulla is hyperosmotic. So what happens is when water reaches the very end, okay, it's going to have a driving force to be reabsorbed. Okay, let's just go right in order here. As we get further and further, we lose most of the solute, so we have a hypotonicity at the top, which is the distal tubule. Very low osmolarity there. As we're going down here, remember there's not a lot of solute left. There's a little bit of urea that gets transported out. That's the urea right there. And that even adds more to this osmolarity, hyperosmolarity down here. So just imagine the water in here does not have a lot of solutes yet. Not yet. Right? It's not very concentrated, I should say, yet. So it's mostly diluted water. Okay, so what will happen is this medullary hypertonicity will force the water out. So then the urine will start to get more and more concentrated at the end here. And that'll drive water reabsorption. This next step is what we already talked about. That's the aquaporins. So it's critical for you to understand that this tubular or collecting tubule aquaporin is basically necessary for the water to be finally reabsorbed at the end. And it's first of all, I'm showing you the water going into the medulla here, but I want you to understand that once it goes in the medulla, the water can then, and I don't have it shown very close to that, but actually the vasa recta would be following that parallel. It would be parallel with the tubule. So what will happen is this goes into the medulla. Some of that water can go and get carried away by the capillary, and that'll go to the rest of the body. So what you have is the ultimate goal there was to cause water reabsorption, to maintain the proper fluid status in the body. So as you can imagine, then if you had dehydration, your body would put more aquaporins into the collecting tubule, right? That would automatically happen through the hyperosmolarity in your pituitary gland blood. That would force more aquaporins, like I said, into the collecting tubule, and that will allow more water to leave the tubule and then get diffused into the blood, and then that would mean less water in the urine. And this is the whole renal countercurrent multiplier system. Okay, and that's it. I know it's a little complicated. What I really want you to take home from this is not to be able to describe the entire mechanism to me, but at least be able to describe, first of all, what gives us the driving force for water to leave the tubule, and that is medullary hypertonicity. What carriers allow water to leave, that would be the aquaporins, and what controls aquaporin concentration, and that is really vasopressin or antidiuretic hormone. And then the final urine, if you're dehydrated, the final urine should be concentrated.